બોલો. 1 મિનિટ લાઈવનો જે કેમેરો ને કેમેરો આમ શું કે પ્રોપર કંઈક દેખાતું ને એવો અપાવજો, જેવો તેવો ના અપાવતા. ऑडियो म्यूट कर दो. हेलो.
patient. So this is the first port which we are inserting. It is by an open technique, which is around 3 centimeter above and 5 centimeter lateral to the umbilicus on the lateral aspect of the umbilicus. So this is the first trocar insertion. These are the special baby divers, we call them baby divers. These are very helpful for the first trocar insertion. The whole game of this surgery is depending on this first trocar insertion. If we are in the right plane, then the whole surgery is then little bit easy. But during the first trocar insertion, if we are directly into the peritoneal cavity, then it becomes very difficult for us to. So after inserting the trocar, first we will see whether we are in the right plane or not. Yes, we are in the right plane. You can see that we can see the posterior rectus sit inferiorly, and the rectus muscle, which is red in color, you can see it on the roof. So we are just insufflating the gas, CO2, and you will see a beautiful vision over here. So we are starting with blunt dissection. We are not using balloon for this creation of this plane. There are surgeons who use balloon for this plane. Balloon is also very easy because you can have hemostasis, but surgeons who are comfortable by blunt dissection can also follow this technique. So after the insertion of the first trocar, we'll just fix it so that there is no leakage of the CO2 from the primary port, because the incision which we make is a bit larger because this is an open technique. So this is a way. Sorry.
Ankur, you are live? Ankur?
Yes, sir.
You are audible. Yes, I am audible.
Yes, sir. So we have just inserted the first trocar.
Okay.
And we are showing how to fix the first trocar, because the space which we are making is a little big space.
Okay.
So this is our technique which we follow to fix the first trocar.
Okay.
So that there is no leakage of the CO2.
Okay.
The gauze piece which we use, we fix it to the port.
Okay.
So there is no leakage of CO2.
Okay.
And then our surgery becomes very smooth. The trocar also get fixed. So this is an excellent view. How is the view there?
Yes,
the view is good, but still there is some obstruction is there. Somebody is obstructing the vision.
No, we'll have to take the. No, you take that camera from now. Yes, yes. You can take it because we are going to stand from here. So after insertion of the first trocar, we will now focus.
Ankur, the vision is lost. We are not able to
No,
see.
he is adjusting, sir.
Okay, okay, okay.
Do you have laparoscopic view, sir?
No, no, we don't have it.
अरे boss. नहीं એની જરૂરત નથી. આપણે લેપ્રોસ્કોપિક વ્યૂ ચાલવાનું છે.
Yes, the OT3 is on, I think, seen.
And now we are able to see.
Ankur, now I think we have a vision. We have a laparoscopic vision. We can see.
So the technique of insertion of the second trocar, we'll take our needle. We have created a space there. We have already marked where we are. So we can see our needle which is coming inside.
Okay.
Can you see my needle?
Yes, yes.
Yes.
Okay, we'll then, we can remove these additions by blunt dissection also, so that you can appreciate the needle very well.
Yes, yes, we can see it in.
Yeah, this is my needle.
Ankur.
Yes, sir.
What is the choice for the primary trocar? I think at which side we have to put a initial trocar? At which distance?
Initially, people used to put infraumbilicus for TEP. But in TEP, when there is small rent formation, then there is a lot of difficulty in creation of the space.
Okay.
So normally we have started doing extended TEP in which
Okay.
we put it a bit higher up, which is
Yes.
3 centimeter above the umbilicus
Okay.
and lateral 5 centimeter lateral to the umbilicus.
5 centimeter lateral to the umbilicus.
Yes.
And
3 centimeter above.
3 centimeter above. Okay.
So the advantage of
ETP.
ETP is that even if there is a small rent, then we
Okay.
are able to continue the surgery very beautifully.
Okay. So this is an advantage over the TEP.
Exactly, sir. And
Okay.
also there is little change in trocar placement. Initially people used to put all the trocar in a single line,
Okay.
and which was a bit difficult for ergonomic wise. So people used to struggle a lot while placement and while dissection.
Okay. Ankur, what are the exact indication for the ETEP? In any hernia, suppose it's a direct hernia.
See, normally ETEP is a bit challenging surgery. So normally what I would suggest is that people should learn how to do basic laparoscopic surgery by doing TAPP. Once they are familiar with the plane,
Okay.
then they can start ETEP.
Okay.
So that they can, because this is not a natural plane.
Okay.
We are creating a plane.
Okay.
And there are certain steps during which you can go wrong.
Okay.
So it is better you get, it is the other way also. People have learned doing ETEP and then they have moved to TAPP.
Okay. Yes.
But what I have learned is that TAPP is much more easy to learn,
Okay.
much more easy to adopt, and then you can shift, because I have done the same thing. I have learned TAPP first, and then
Yes.
I have moved to ETEP.
ETEP. Okay.
Where is the place of second trocar? Ankur.
See, the second trocar is in the line of the seminularis.
Yes, yes.
So when we insert a needle, first we dissect up to the seminularis, we insert a needle, and then after inserting the needle, we see whether the needle is where we want our trocar.
Yes, yes.
If you can see, I have just drawn priorly where my 3 trocars are going to be. This is the umbilicus.
Yes.
Yeah.
3 centimeter above lateral was my first
yes,
port.
yes, yes,
Then I have drawn the seminularis.
Yes.
My second port is here. Now third step is I'll make a plane over here. I'll insert my second port, and then the surgery will be very easy.
Very good, very good.
Yes.
So now I am just dissecting the flimsy tissue, and then we will insert.
So your both the trocars working are above, just above the semilunaris. This,
Exactly,
arcuate,
sir.
Arcuate, yes. We can see the arcuate.
So this is the midline,
Yes,
and this is the posterior rectus sheath.
yes, yes.
So normally there is a new concept which is coming in ETEP, is that we have to cross over. So this is the step which is to be learnt.
You have to go beyond the midline, yes.
Yeah. So normally this is how we do crossover. You have to cut the posterior rectus sheath. I'll change my instrument. See, each step has a specific instrument. This can be done by a bipolar also. If you have a cutting bipolar, this surgery, I have started using different instrument, and there are specific instrument which can make your surgery very, very, very easy.
So you are cutting the posterior rectus sheath and you are
Yes, sir.
just above the transverse fascia.
Exactly.
Yes.
So normally see, this is the plane. I'll just make a bit. I'll just expand this plane so that I can show you that which is the exact plane which we are going to go.
Yes.
See, normally for hernia surgery, fat should always be up. So fat is always on the roof.
Yes.
You have to dissect in such a way that the fat always remains on the roof. There are chances where you can have fat below, but always make it a point that fat should always remain up like this. There is always a flimsy addition. So because of that,
This is also a vascular plan.
yeah,
You can see it.
this is a very avascular plane.
Yes.
So you have to just dissect.
So it will fall automatically with
Yes,
less
yes, yes.
energy. This.
So, to your opinion, which energy source is better? You mean to say unipolar or bipolar? If preferable?
Exactly. See, normally, sir, what I feel is that you should know your energy source very well.
Okay.
So normally, if you're now there are very good. Initially, there were not good instrument
Okay.
for bipoling the energy source.
Okay.
So the instrument which were available were not that good because it used to. Bipolar energy. So initially they just used to coagulate.
Okay.
They never used to cut. Now they have made specific instrument in which they coagulate and also cut.
Okay.
So you need not have any scissor with that. So the job is very easy.
Okay.
So only a bipolar instrument which you have can take care of sealing, cutting, and dissection.
Okay. So you mean to say bipolar vessel instruments are always better?
Definitely, sir. Bipolar, see, normally unipolar, if you see, it is
Okay.
just coagulating from one side.
Okay.
When we are using a bipolar, if they will coagulate from both the end, and the energy source is very good for vessel sealing.
Okay.
It is a vessel sealing energy.
Okay.
So we have done with the hemostasis. See, normally in ETP and TAPP or any laparoscopic surgery, the hemostasis should be done very well. Otherwise, what will happen is that now we are having a luxury of using an Image 1S, which is a very good system. But for the young surgeons and who are starting their practice, they will not have such high-end devices. So normally when there is small amount of blood, the whole area gets dark. And once the area gets dark, you are not able to see what you are cutting or what you are sealing.
Okay.
So what I feel is that your hemostasis should be done very, very well. Your anesthesia should be given very well. The BP, blood pressure of the patient should also be very low.
Okay.
So for any laparoscopic surgery,
Okay.
these are the key things which you have to see. So we are cutting the rectus sheath.
Yes, you enter the EP space.
Yes, sir.
Yes. We can see the fat
Yeah.
extraperitoneal.
So normally what I feel is that in laparoscopy, we never have to hesitate in changing the instrument.
Okay.
Because each instrument, see, normally if I am making a space here,
Okay.
if I am having this is a spatula which I am using, it is an excellent device because it will cut and the blunt end, it gives me a superb dissection also. See, I can do this. I can't do this with hook because when I am doing such kind of dissection with hook, the fibers will get entangled and I'll keep on getting problems. So this is the best energy device. So see, normally here, this fat should go down. This fat should not remain up.
Yes.
So normally the rule for fat is different for different things. If we are cutting the fat over here, then
Yes.
we will go directly into the peritoneal cavity.
Yes, you have to keep certain fat over this EP space.
Yeah.
So nicely you are dissecting nice, you are making good space.
So you have to keep on confirming that whether you are not doing more what is required. So we'll just see whether we have reached our space or not. Still a bit of dissection is left. So we'll first.
So you have gone beyond the midline and on the right side.
Yes, sir.
Yes. We are seeing one layer covering the muscle above.
Yes, sir.
Yes, that is a good thing. So we are doing the similar dissection in TAR also.
Definitely, sir.
कान पर कान पर चोटी
So E-tape RS is the
bas.
new thing which we have started using for umbilical hernias also. So in
Okay,
that
okay.
surgery also we will be creating the same plane.
Yes, yes, yes.
So in that also we have to do crossover to go on the other side.
We can see the second needle.
Exactly.
Yes, yes.
So we have reached the desired place where we have to keep our third port.
It is just below the arcuate line. Yes.
Exactly, sir. So normally small incision
Put putty आपको
and we'll place our port. The needle is our marker.
Yes, yes, yes.
So we have to place the needle because the direction in which the needle is, we have to insert our port also in the same direction.
Same direction, yes.
If we go in the other space, then we are going to go into the peritoneal cavity.
Yes, yes.
So once we are done with our port, then the surgery becomes very, very easy.
Nicely seen. You have made a very, very good tunnel. Very good tunnel is seen.
Thank you, sir. So now we have to just
Ankur, can you show it from the outside so that we can see that how the ergonomics looks? Okay, this is fine. Right hand working, left hand working, telescope is placed
Knife.
very, very nicely.
artery and a knife.
Yes. And
so here we have reached.
this is surgeon friendly. Yes, this is a good.
So this is a triangulation
placement.
which we have devised because initially when we used to do TEP, it used to be in the 3 line. So normally when there is bilateral hernia,
Yes.
you will always have a problem there.
Yes, yes. This looks very nice. So that ETEP has a more advantages over the TEP.
Normally in
Yeah.
ETEP, you see if you are not knowing to suture, then there is no problem. You just have to just keep a mesh. Even taker is not required. So today we will do the same thing. We are
Okay.
going to use a anatomical mesh. We'll just place the mesh and we'll come out. So the time of
Okay.
suturing and tacking,
Okay.
the expense will also decrease, and also the cost will also decrease, and the time will also decrease.
Okay. So
Because
that
just after placing the mesh,
Okay.
we have to just come out. And the
Okay.
mesh will stay in that same compartment. It is not going to move at all because it is a closed compartment.
so yes, can we do the ETEP in a bilateral hernia cases?
Definitely, sir. It is very,
Yes.
very, yeah.
Same ports, same
Ah.
port side.
Ports will be the same, or you have to somewhat, it is a somewhat different ports.
No, sir. The port are going to remain the same in
Same.
ETEP also,
Very
in bilateral.
Okay, okay. Suppose the patient is indirect hernia, this is also fine?
Yeah, this patient is also having an indirect
Great.
sac. So
Okay.
normally the same thing I am telling.
Okay,
So if you do, the learning curve is like that. You do TAPP,
Okay.
you understand what is the space,
okay,
then you can start with ETEP,
Okay.
you select your case, you select your cases, initially you take small bibinocils, and after that, once you are confident with the area, then you can go and venture for indirect sex.
okay, fine. This is good. The dissection is very clear, hemostasis is good, the tissue identification is also fine.
So we are just bringing down the sac.
आप इससे ऊपर आ जाओ, फट दो उसको। हाँ, नाश्ता वास्ता करके ऊपर आ जाओ। फट दो ऊपर आओ, we are waiting for you.
देवलाई जाओ। Hello, Ankur?
Yes, sir.
Whether we have to proceed from lateral to medial or medial to lateral, what is your choice of
No, sir. We'll directly make a tunnel. We go
Okay.
to the pubic tuber, pubic symphysis, and then we then go laterally.
So you mean to say, first of all, identify the pubic tubercle,
Yes, sir.
identify,
Pubic symphysis and the pubic crest, the whole of the pubic. And after that, we go laterally.
then you go laterally.
Yeah.
That's fine.
So normally, my advice is that you should always, for laparoscopic surgery, there are few things which we have to keep in mind.
Yes,
That it should be absolutely a sterile condition.
that's
all
fine.
all the instruments should be autoclaved. There should be no use of formalin in any hernia surgery,
Okay,
because there are a lot of chances of getting atypical mycobacterium. You will have to explant the mesh.
okay,
So these are few requisites. You can also keep a small autoclavable bottle which have hot water, so that whenever there is a lot of fogging,
okay.
you can use it to clean your scope. So I had a bit of oozing over here because there is a lot of fat.
Yes,
So so this is the hernia, and which I'm going to reduce.
nice, nice dissection.
This is the pseudosex which I am taking it up.
Yes, pseudosac is seen very nicely. Yes,
The whole pseudosac has gone up. We have to dissect 3 to 4 centimeter below it, so that when we place our mesh, the whole bone should be exposed.
okay,
See, the causes of recurrence is inadequate dissection.
okay.
Until and unless you do a adequate dissection, because if you think that I have reduced the sac and you have not dissected the area well, so the mesh will get unrolled and the hernia can again form.
Okay,
So normally patient asks us, okay, what are the chances of recurrence? So recurrence is in the hand of the surgeon. So
okay.
if you are not dissecting well, you are definitely going to get recurrence. So you have to follow few principles. I'll be keep on telling what are the things which we have to keep on seeing while dissection.
Okay.
So, Ankur Bhai, I used to teach my residents similarly. There are 3 enemies of the surgery. One is bleeding, second is infection, and third is fibrosis.
Definitely, sir.
And similarly, in hernia also, I teach 3 things for a hernioplasty. One is to try to avoid the infection.
So in hernia surgery, it is of utmost. I tell my staff also. So if you are infecting a patient, the patient whole year is gone. So to diagnose that patient has got infection or not, it takes around 2 to 3 months. And once the patient has diagnosed that he has got infection, we send him to the infection specialist doctor. He start on some medicine, but until and unless they keep him on medicine for around a month or 2, finally they get tired, and then we have to explant the mesh. And after explantation of the mesh, the treatment starts for around 6 to 9 months. So the whole year of that patient is gone.
So there are only 3 fears of the mesh. That is, one is infection, second is unrolling, rolled out or displacement, and third is shrinkage.
Definitely, sir.
So these are the 3 problems with the mesh surgery.
So you have to know your mesh very well.
Yes.
You have to see that, take care that when you are placing the mesh, Your instrument should be very well. You have to change your gloves. Your assistant has to change the gloves. See, this is the peritoneal fold which
Yes,
is there.
yes, we can see the edge. Yes,
This is,
yes.
And this is the cord.
This vas, we can see the
Yeah,
vas.
so now we are dissecting. We'll make a space between the vas and the peritoneum.
Yes, yes, yes.
So that the mesh should be in between them. If you are placing the mesh above it, the hernia is going to go from below
Yes,
and you will get a recurrence.
Recurrence, yes, I
So
understand.
this is the most important step of any laparoscopic hernia,
Yes, yes.
whether it is TAPP or TEP.
Yes, yes. You have to bring the peritoneum edge down well.
So the principle is that the peritoneum fold should go up to the vas is turning medially.
Yes, yes.
You have to dissect up to the medial going of the mass.
Yes, yes. So peritoneum should not enter behind the mesh.
Exactly.
Peritoneum should lie over the mesh.
Exactly.
Yes, yes.
The space should be adequate.
Adequate.
Yeah. So you have to create 2-3 centimeter adequate space.
Then you can very well place it.
Exactly, sir.
Cautery. Cautery.
તો ચાલુ કરી દે ને. હા તો બંનેનું ચાલુ.
Welcome, Sanjay bhai, welcome.
Gasura sir, Amit bhai has also started, I think. So,
Okay. Yes, yes. You can switch over to the Amit bhai.
yes.
Yes.
Amit bhai, tell me what is the patient? Which
hello.
type of the hernia?
Hello, can you hear me?
Yes, yes, yes.
Yeah, good
Amit,
morning everyone.
Good morning. Good morning.
So, this is a young chap, 35-year-old with bilateral inguinal hernia. Indirect hernia. This is the right side, is a small defect, but the more challenging is on the left side.
Okay.
You can see the sigmoid is adherent to the peritoneal fold.
Amit,
So,
Amit, we are able to see from the exterior. Yes, yes, yes.
Okay, now you are visible.
Now,
Okay, so this the left side is the more challenging because the sigmoid colon is adherent to the peritoneal fold.
okay.
Okay, so and that is a larger hernia on left side. So we are starting with left, and then we will do the dissection on the right side. Okay, so patient is in a Trendelenburg position, and we have our 10 mm trocar in the umbilicus
Okay.
and 2 5mm trocar in the mid clavicular line.
Okay.
Just at the level of umbilicus only.
Yes.
So we are starting with formation of the flap.
Okay.
Pankaj bhai is with and Dhaval is with me at present.
Okay.
Pankaj bhai, please. Vijay bhai.
Okay.
The blood pressure is 130, so we want to it less than 100.
Okay. Yes, yes, sir. What is, yes. So in laparoscopy, your choice is the blood pressure should be around 100.
Yeah. That is essential because
Okay.
we are going to dissect in planes, and if the BP is high, it will lead to oozing and bloody filled.
Okay. Okay.
The cautery is not working. Can anyone help me to correct the cautery?
Amit bhai, till the cautery is okay, just show me the anatomical landmark
Sure.
that one has to see
Sure,
in
sure,
laparoscopy.
Yeah. So, so this is the we can see the Foley's catheter dome of the bladder.
Okay. The patient
Here?
should be always should have a Foley's catheter.
Yeah, I always prefer
Yes.
TAPP.
Yes.
Okay, and this is the midline.
Okay.
Now this. So this is the obliterated umbilical fold.
Okay.
Fold of and this here it is on it is not that mature. It is more mature on the left side. Okay, on right side it is a little bit obliterated.
Okay.
Now we are not supposed to do any kind of cut on the peritoneum between these two fold. Okay.
Okay. So this is the basic.
Yeah.
Okay.
Now can you hold please? Yes. This is a left side anterior superior iliac spine impression.
Okay.
So my cut will start from here.
Okay.
It will go horizontally up to the medial ligament or obliterated umbilical vessel fold. Okay.
Okay.
This is a horizontal cut I will create, and from where I will go to the pre-peritoneal space.
Okay.
Now this is okay. just a minute.
ETO.
We have to look for inferior epigastric vessels also. I'll just show you. Please clear the camera. Garam pani, please.
Ankur,
Yes, sir.
I think you are on the screen.
Yeah.
You can start the procedure. And
Sir, our dissection is almost complete.
okay, that's fine.
So if you can see, we are very low.
Ankur, I think we are again with the Dr. Amit.
Okay.
Yeah. Yes, so sometimes inferior epigastric you cannot see very well. See, in this case, it probably should run here, and the hernia is lateral to it, so probably it is a indirect hernia. If the direct hernia is there, the hernia will be from this part. Okay.
This is a site for
Direct
hernia.
Here we can. It's on right side now. We can see the iliac vessels.
Iliac vessel.
Okay. You can see this is a vase here running down.
Yes.
This is a deep inguinal ring.
Deep inguinal ring.
This is a vase, and these are the
એટલું
gonadal
કરું ને,
vessels.
પાછી થોડું હજુ એટલું
These are the iliac vessels. This is artery. This is vein. So this is a triangle of doom.
Triangle of dome.
Okay,
Yes.
we should not put any tacker here because it will be a torrential injury to the vessels. And this is a symphysis, and the tract is called iliopubic tract.
Okay.
It is running from here to here. This is a deep ring. Okay, so this particular triangle on right side of the this right gonadal vessels.
Okay.
This is called triangle of pain.
Okay.
Here the ilioinguinal and iliohypogastric nerves passes from lateral to medial aspect. So here also we are not going to use any kind of tacker. Okay. So this anatomy was not clear on left side, so I showed on right side. Because on left side the sigmoid colon is there, so everything is hidden behind it.
Yes.
Okay.
Yes, you can start from the right side. Let's see.
I am starting from left first
Left side.
because the left is larger.
Okay.
So my preference is always the larger hernia to tackle first,
Okay, that's fine.
and then go. on
Amit
the-
bhai, can you will you describe about the peritoneum flap raising? Where you put the cut?
Yes. Yes. That's what.
At what height? After
Yes.
palpating the anterior superior spine.
Yes. Just wait. Let me check the cautery first, and I'll explain. Cautery batao. Okay, it's okay. So this is my impression of the left anterior superior iliac spine.
Okay, fine.
And I am starting my incision almost 1 to 2 centimeter above and medial to that impression. So this is, I'll just do the tattooing, and I will come. Badu.
Lateral to medial.
Yes. So this is my peritoneal cut. I will extend from lateral to medial aspect. Now to keep it horizontal and not shifting the line, this impression is it has created very good pneumoperitoneum also.
Okay.
And I can determine the line where I am supposed to incise the peritoneum. It should be horizontal as much as possible.
Okay.
And second thing, the cut should be at least 4 or 5 centimeter above the deep inguinal ring. Okay,
Deep inguinal.
so that we can spread mesh nicely.
Okay. What is your choice for the instrument? Do you use hook or do you use a spatula?
Majority time in this I use hook.
Hook is okay.
Yeah, and scissor is also fine.
Okay.
Whatever is available and
Yes,
nicely
yes.
working.
But choice-wise, you are more comfortable with the hook.
Yeah, I am a hook surgeon.
Hook surgeon. That's good. Yes, yes, yes.
My majority is laparoscopy. I prefer hook in majority dissections
Okay. Fine.
whenever it is feasible and viable.
Okay.
Okay.
Which is this plane? Amit bhai, which is this plane? It is behind the transversal fascia.
Yes, yes. I just explain. Just a minute. So see, this is a peritoneal fold.
Yes.
Okay, and this is a
Fascia transversalis.
yeah, posterior
Layer
of the transverse fascia, and it is also merged with the posterior rectus sheath. Just a minute. Pani apo garam. Please clean the scope. So that important thing is fascia transversalis is splitted at the level of linea semilunaris.
Okay.
And it has a posterior and anterior this split. So we have to cut the posterior split, and I will demonstrate that at linea semilunaris where it merges.
Yes, yes, yes.
Okay.
So you have to enter between the two layers of the transversal
Yeah,
fascia.
yes.
Yes, yes. And you have not to bear the overlying muscle. Yes.
Yeah, as much as possible, but sometimes I don't mind to bear it because it varies from patient to patient. So there is if it's get bare, there is no harm.
Yes.
But we should try to avoid it.
To have a good
See,
avascular plane.
here I have left the fat above to
Yes,
the muscle.
yes. Yes,
Here
yes.
I have exposed the muscle.
Yes, yes,
But now I got the right pain. So the fat is going towards muscle.
Towards the muscle.
Okay.
Yes, that is good. Very well seen.
CO2 નીકળી ગયો છે.
હા, એ તો હોવું જ જોઈએ. Posterior transverse fascia should be down.
Okay, so we are back now. So I will cut this posterior layer up to the medial umbilical ligament or obliterated umbilical vein fold,
Yes,
whatever you describe it as.
So, I mean, basic technique is that you should keep the peritoneum bare and keep the fat away. What
Yes,
is your
fat is always to the parietes.
okay?
Okay, and we should try to push it up.
Okay, so there should be minimum fat or no fat.
Yeah, exactly.
चल ना उसको बोलना 5 मिनट मेरे को दे दे अभी मेरा हो गया है.
So we can see here at linea semilunaris this posterior leaf of the fascia transversalis is getting
મેચ લઈને ઉભા રહે ને એને
over. So there from there I have to
મેચ બતાવીને
cut
પછી
it
અમે કરીએ
longitudinally.
અમારું ડિસેક્શન પૂરું થઈ ગયું છે.
See, these are the two fold of the fascia transversalis. So here I am now absolutely
હા
at
અહીંયા સ્વિચ કરવાનું છે 5 મિનિટ
pre-patellar
કહેવાનું કોણ
on lateral
પછી એ
aspect.
એમનું ચાલુ રાખે તો કઈ વાંધો નહીં.
Laterally you are totally on the preparator space.
Yes.
Yes,
This is the sleeve where
Two layer of the transversal fascia.
yes. So I have also taken the posterior rectus sheath with the posterior leaf of the fascia transversalis. I usually do it. There are different opinions, but I prefer it because it gives some strength to the posterior leaf of the peritoneum.
Okay, that is
So
good.
while closer, there will be less likely of tearing of the peritoneum.
Yes.
Hello, Amit bhai?
Yes.
Dr. Sanjay.
Yes.
Ah,
Sanjay bhai,
it
bolo.
always necessary to take the transverse fascia with the peritoneum?
Posterior leaf transversalis fascia, it's bound to happen. You have to take. There is no option.
Okay.
But the posterior rectus sheath is an option.
Okay.
I take it just to give strength to the flap.
Okay. If flap is already strength, then we
yeah,
can.
you can avoid it also.
Okay, okay. And this peritoneal incision is like a hockey stick or other else?
Horizontal.
Okay, okay. So which is better?
नहीं, I prefer
घासुरा साहब ने बात
horizontal.
करने ऊपर
It
फोन
is
करने
easy to
घासुरा साहब
close.
कि साहब 1 मिनिट है यहाँ बाजू करो ने મારું અહીંયા ચાલુ કર દો ને હું વાત કરું.
Amit bhai,
Yes.
can you ask them to just switch over to Ankur?
Yeah, please
Okay.
shift to Ankur.
Ankur is on the final
Yes.
step.
Hello?
Ankur, now
Yes, sir, can
now
you
you are
hear me?
seeing.
Give me the grasper.
Now we are able to see.
ઓકે સર
Okay.
કેન યુ હિયર મી સર
This is a pseudo sac. Seen
Yeah,
nicely.
so normally what we do is we take the pseudo sac and we
Okay.
BP
take
down
it to
to
the
around
superior surface of the ramus.
Okay.
So normally there is no dead space left there, and there are some instances where we have seen that some patient of ours, they come to us that there is some amount of bulge present. So
Okay.
normally we have made a policy to just fix the tech, and normally if you can see here,
Father?
the whole area has got flat.
Yes.
The
This is
whole
a
area
very
has got flat.
this is a very good suggestion. Yes, that is
Yes.
fine.
So normally
So-
now we are going to place a 3D mesh.
Okay.
So we are going to use the barred 3D mesh, which has been specifically designed for our pelvis. So in that we have to just take the mesh and we'll just insert it, and it is going to take the shape of the space which we have dissected.
Yes.
So I'll just be changing the gloves till the time he is going to open the mesh.
Okay.
So this should be a policy that once you are going to take the mesh in your hand, you have to change your gloves.
Okay.
The gloves should be new. You take the mesh. So if you can appreciate, this is a different kind of mesh, specifically designed. So you can
Yes.
see the marker also. M is written for medially. So this will go in the medial part, and the other end will go on the lateral aspect. So normally the other mesh which we used to use initially were flat meshes. So this has a specific shape. So if you can appreciate the shape of the mesh.
Yeah.
It is like a bowl. So it is going to exactly fix in the pelvic cavity, and it is not going to move. Very simple to insert. Just hold on the medial aspect, and then you have to just push.
M is for the medial, so that we have to keep the M medially. Yes.
Yes, sir.
This is a case of extended TEP. Rishabh. Dr. Ankur is operating.
See, the beauty of extended TEP is that if you have appreciated, there has been a
Saaf
small
karo.
hole which we
Saaf,
created, but still I am able to get a space and I am able to operate. So this was not possible when we used to do conventional TEP. In that case, you had to struggle so much that you have to convert it to TAPP.
In conventional TEP, we were putting 3 trocar in the same line below umbilicus. So we were struggling for dissection and for placement of the mesh. Now it has changed.
See,
The camera
it
point
is
is
so
above
easy. It is so easy
Forward
that
to the
I'll just place the mesh. It will hardly take any time for me to place the mesh.
Yes,
So
yes.
it is going to take the shape. And we are done. We are done with the surgery.
Yes, surgery is almost complete.
So the most important step, last important step, we have to take this back. We have to take this back. We have to place the fold of the mesh in between these two structures, that is the
Lower.
peritoneal fold and the cord structure. and then you have to place this. If you are placing the mesh above this thing, then again you can get hernia.
Yeah, so the lower edge should be behind.
Yeah. And this is, we are done with the surgery.
Yes, yes.
We are not going to fix this mesh.
Yes, yes.
CO2 बंद करो.
It has got memory to be there and there.
Definitely, sir. So I'll just be showing, I'll desufflate. I'm desufflating right now. Again, I will insufflate and show you. The mesh is not going to move.
Yes.
So now we are going to start it again. We are going to start it again.
So you have done you have removed the gas from the abdominal cavity.
Yeah, we have desufflated and we'll insufflate again. So after insufflating, the mesh will be in the same position.
Put a mesh and again
See, normally after to stay in place. I mean, initially you are normally you are beginning the surgery. For them, these mesh are the ideal mesh because they are going to get less struggle in placing the mesh.
okay.
Because placing the mesh is also a big deal. Normally it takes around 15-20 minutes to just settle the mesh.
Yes, yes, you are always you're right.
So normally my message to the young surgeons are that whenever you start any surgery, the things you should attempt, that should be very easy. Mesh placement should be easy, suturing should be easy, your case selection should be easy. Then only you get confidence, and once you get confidence, then you can take difficult cases. So we are just completing the surgery. We have just insufflated, and now we are just closing. So thank you. You can move to Dr. Amit sir's OT.
Nice surgery. Thank you.
Thank you very much, sir.
Flap the card. Hello.
Hello, Amit bhai, bolo.
Yeah, am I with you? Okay, so we have created the flap. Initially, we did the medial dissection first. So I'll show it. Here, this is the medial dissection.
TAPP. That was TEP.
So the medial dissection, we can appreciate the symphysis and pubic crest, pubic tubercle, okay? And we have reached at least 1 to 2 centimeter below the pubic ramus. So that is the lowest
level of dissection.
Yes, for us. After that, we did the lateral dissection. Set password. So this is a lateral dissection, and you can see that we have kept all the fat on the abdominal wall. We don't want to disturb the nerves traversing there. Thereafter, we came to the deep inguinal ring. Okay, so the important aspect is that sigmoid was adherent to the peritoneal fold. So we are not supposed to dissect this area.
Yes, yes.
Otherwise, it will lead to puncture into the peritoneum.
Yes, yes.
Okay, holes into the peritoneum. Patient had a lipoma of cord. I have dissected partly. Now there is also still some fat is remaining, so I am doing all is blunt dissection. Okay, very minimum use of cautery, and this is possible if the blood pressure is kept low. So that is the why we need low blood pressure. Otherwise, due to this blunt dissection, there will be significant and the field will be very disturbed. Now, this is the cord. You can appreciate vase here.
Yes, yes, we can see the vase.
Okay, and the cords. So I am just dissecting gradually. No, there is no hurry. We have to be very gentle dealing this area. The aim is to create a peritoneal fold so that the till the vase is going medially, turning medially.
Thank you.
So here we can appreciate that it is going gradually on medial aspect. See, we can see the vase is going medially now.
Amit, your choice is to separate the fat with the Maryland. You are more
No,
comfortable.
two graspers.
Two graspers. Okay,
I
that is
use
fine.
two graspers.
Two graspers.
Majority blunt dissection.
Okay.
I do use hook in between or any other gadgets in
Okay.
between whenever
Okay.
it is needed. But
Okay.
majority time I prefer blunt dissection.
Blunt dissection. Okay.
And that's why I prefer my the blood pressure low.
No.
Yes.
Yes.
So you can see the vase is going down and medially. It is taking its turn. So that is the limit of the dissection at the level of vase.
Okay.
These are the cord structures. So I will separate it out.
Yes, core structure is seen very nice, very clearly. Vase is seen also very clearly.
So these cord structures I have separated out.
Yes.
And these are the tissues I will cut.
Yes. You have to preserve the vase and the cord structure,
Yes.
main vessels.
Yes.
Rest of the thing, I think you can
કોટરી લગાવી દો
resect it.
અહીંયા કોટરી લગાવી દો ડબલ કોટરી લગાવો અહીંયા.
Amit, you are comfortable with a monopolar or bipolar cautery?
I like bipolar if the forceps is of my choice.
Okay.
Bipolar is always better. There
Always
is
better.
no doubt about it.
Okay.
But it should grasp the tissue also. Many times what happens, bipolar is good, but it does not, see, this is the lipoma of cord.
Okay.
Is separated out from the entire cord structure. Now, the next step is I encircle the entire thing just to show that all dissection is complete. Many don't prefer this, but I prefer just there to assure that the all fat, everything, all entire hernia sac is reduced. I am holding very lightly, and this is the entire thing is encircled. You can see the entire cord is encircled, and there is no whatsoever lipoma of cord or sac is remaining. The next step is we have to peritalize the cord as much as possible to avoid any kind of future recurrences. Who copy them?
Amit, what is your choice for peritalization? You have to go from medial to lateral or lateral to medial, or just to find out the sac and separate it?
My choice is what is best in that particular situation.
Yeah, that is fine.
If I find comfortable doing from medial, from
Okay.
lateral,
Okay.
whichever plane is opening up, I
Okay.
will follow it.
Okay, that is fine.
And this is, see, I have, the peritoneal fold is absolutely down.
Yes.
Okay, this is the peritoneal fold. We can appreciate it. These are few things. Fibers I have to cut. Okay, now give me grasper. So I feel our dissection on left side is almost done. How to determine is just to hold the fold of peritoneum and elevate. See, there is no whatsoever dimpling at the deep ring. Okay, this is our deep ring. So there is no whatsoever dimpling. The cord structure, the gonadal vessels are very nicely dissected. The cord is also dissected well. There is some tissue here. We will just do blunt dissection and separate it out. If there is a femoral hernia, it will be here. There are the external iliac vessels, and it is traversing the femoral just below the inguinal ligament. If there is any femoral hernia, it will be here. But there is no hernia whatsoever. So our dissection is complete on left side. This is a lateral dissection. Hook, please.
Dr. Paresh B. Somani, you are welcome. Fine.
So we have completed our dissection on left aspect, and this is the midline. I just want some more dissection there so that we can cross over easily when we are coming from right side. Okay. Now we'll shift to right side.
Okay.
I'll ask Pankaj Bhai to move on right side. I usually prefer to dissect from the mid of the table, head end of the table. So my position will remain the same for either side. The camera person will move from left to right side to start dissection.
Amit bhai, what is your choice of the position? Do you put the patient in which position?
It's a steep tendon position.
Okay.
So that my back is not so much get hurt.
So the
Just a minute.
basic principle is
Yeah.
that the surgeon should be comfortable.
Always.
Always.
My take is that first the surgeon's position should be comfortable, then
Comfort.
patient's.
Yes, yes,
Because patient is under anesthesia, we can apply all protective measures to avoid any injury to patient.
Okay.
But now then the most important is surgeon's position. Then only he can perform a better surgery.
Better surgery.
And for many years.
So it is a basic dictum. It is applied at everywhere.
Yeah.
When you are flighting in a flight,
True.
it is always written that first of all try to save yourself. Yes,
Absolutely.
and then you can save others.
And that's why the robot is a future.
Robot is the future. Yes.
So now I am starting the right dissection. This is the ASIS, and this I have started 1 centimeter above and medial to the ASIS on the right side.
Okay.
The same way I have punctured the peritoneum, and I will hold with the forceps, and there will be pneumo going very nicely extraperitoneally. I will follow the horizontal line.
Yes.
We can see this horizontal line. That is what I am supposed to cut.
Yes, yes.
Clean, please. This fogging issue is always going to be a trouble,
Yeah.
especially in a monsoon season, because of
Okay.
the moisture in the air. We want the expert camera person to tackle these issues as quickly as possible.
Pankaj bhai, try to help Amit bhai.
No, he is doing excellent job.
Excellent job, yes.
Even though he is not that
Ah,
best in his physical
he's-
condition.
He is not a body, fit body wise.
Yeah, but
Yes.
he is helping with the best.
Yes, now it is clear.
Yeah. So I will continue the
Your choice of dissection is lateral to medial, always.
most probably because the ASI first landmark is ASIS.
Yes, yes, okay.
So from there I puncture it, develop the let the CO2 go into extraperitoneal space,
Yes,
and then follow it to the medial aspect.
okay.
So I have to check where to till where I am supposed to incise. So it is here. Okay, this is a medial ligament. And we have to also check that we are at least 4-5 centimeter away from the deep ring. Sometimes it may we may mistake and go deep.
Okay.
So here, what happened, contrary to the incision on the left, that I have just we can see the posterior lip of the fascia transversalis very well here.
Yes.
That I am also going to incise deliberately. I don't. I want my flap little bit thick so that I can close it easily.
Okay, that is the basic thing. Yes.
So I
Amit
will-
bhai?
Yes, yes.
Distance of incision is from defect margin or deep ring?
Miss, here the hernia is not that big.
Okay.
That's why I am referring it to the deep ring.
Okay.
Of course.
Then normally
Yeah.
from defect margin,
Yeah. Absolutely.
which length is better?
4-5 centimeters
Okay.
from the defect. Definitely, if the large hernia,
Okay.
we have to we need to have at least 4-5 centimeters of the mesh.
Okay, from defect margin. Okay,
yeah.
okay.
So this is the posterior layer Dr. Gasura sir was discussing, which I am incising deliberately so that my flap remain thick. I don't like thin flaps. And here, as soon as I see fat, push it up. Fat, push it up. And so that you can see the rectus muscle is very well covered by a flimsy layer. Rectus muscle is not getting exposed. And this is a lateral part where the fascia is getting split. So that we have to cut vertically. Okay. As I feel my this thing is adequate, and this flap is that is done now. Now I will shift to a grasper.
In audience, all are free to ask any questions, so that if you have any query, you can always
So
ask
again,
to Dr. Amit bhai.
first do the medial dissection. See, with the grasper you can see it's so easy. Traction and counter traction. My lower end is pushing down, and you can see the White House, very famously called the symphysis, is now visible. And I will continue
Hello.
the same flame, and
Hello, sir.
I will merge it.
How you differentiate between direct and indirect from internal view?
Amit bhai, Dr. Sutaria is there.
Yes.
He is asking you a question. He is a surgeon. He is a senior surgeon, and he is asking you a question. Yes.
Yes.
Yeah. Sir, how you differentiate direct or indirect from this laparoscopy view?
Okay, so sir, see, I have to come out. Yeah, this is the deep ring. Okay, my hernia sac is going like this, so it is lateral to the inferior epigastric vessel. The inferior epigastric are not very well visible here, but they are here, at this level, and going like this. So when the hernia is sac is lateral to the inferior epigastric, it is indirect hernia. When the hernia is from here,
Yeah.
this place,
Yes.
which is medial to the inferior epigastric,
Yes.
then is a direct hernia.
Yes, yes,
Yes.
yes. Now it is very clear that if it is medial to the inferior epigastric,
Yeah.
it is a direct hernia. If it is lateral, it is indirect hernia.
And when sometimes, suppose in this case, the inferior epigastric are not that prominent, we
Okay.
can take reference as a deep ring. The
Okay.
deep ring is always easy to identify. This is a deep ring, okay? Where the vas deferens is going up, the gonadals here are going up
Okay.
and making an apex, okay? And in between them, you can see this is a common iliac vessel, an external iliac. Sorry, now it is called external iliac because of the division, and this is the external iliac vein on right side.
Okay.
So this is a triangle of Doom, okay?
So in the apex, there is a deep ring is there, so
Yeah.
that if it is medial, then it is a direct hernia.
So
That's fine.
as I have already dissected on the left side, I will combine both planes from right and left side. So see, now I have both planes are now together. So this is symphysis, this is retropubic plane, space, sorry. And now the left side and right side is together, okay? So after completing the medial dissection,
Okay.
I will go to lateral aspect. Here again, fat with the parietes.
Always keep the fat
Yeah,
towards the towards the parietes.
parietes. No, you don't need any electrosurgical gadgets or anything. Just if you are in right plane, a swipe of grasper, blunt dissection is more than enough.
So you mean to say that you have to find out the exact plane,
Right
exact
yes,
exact
yes,
plane
that is very essential in hernia surgery. Of course,
Okay.
in any surgery,
in any surgery.
for hernia, it makes a lot of difference.
Your anatomy should be clear, and
Yes,
you
yes.
should know the exact plane,
True.
well defined.
So after lateral, now we are converging toward the deep ring. And from medial aspect, lateral aspect, I don't go into all those things. Wherever you are comfortable, just carry on the dissection. But we should not lose the plane. Or if we have lose, we have to come to correct plane as soon as possible.
Okay.
And if there is a unwanted bleeding or all those, if you find the further dissection difficult, that means you are in a wrong plane.
Okay.
Grasper. So this is again probably the lymphoma of cord going into the deep ring. It will come in a while.
Okay.
I have to cut a few fibers.
Few fibers.
Yeah, before it gets separated easily. Hook. So it's a.
Amit bhai,
Yes, sir.
this is more or less a lipoma of the cord on the
Yes,
right
yes.
side.
Yes. So the patient had a bulge on coughing, and on ultrasound there were hernia defects. So many times it is not that the entire sac is going deep. Many times these are lipomas which
Which
leads
mimics
to-
like hernia, yes.
Yeah, which leads to symptomatic symptoms because of the pain. When patient exerts, this got entangled at the deep ring,
Yes, yes.
and patient will have pain.
You can see the lipoma of the cord very clearly.
Yeah.
Suresh bhai, this is deep ring. Suresh, this is deep ring. So it is indirect.
Grasper, please.
Oh, Radni bhai, welcome, welcome.
Radni bhai, you are welcome.
આ કોટરીનો વાયર ઉપર લઈને સાહેબ લબડે છે.
Thank you. Good morning to all.
Good morning, sir. We have to pull it gently, but constant pressure, so it will get separated from the surrounding tissue gradually without. Here we can now appreciate the pseudosac. See, I am pushing it up.
Yes.
This is a pseudosac.
Pseudosac.
This is a pseudosac. I am pushing it up.
Yes, the pseudosac is seen very clearly.
Pseudosac pushing up, up. Pushing up. Okay. Now we reassess the situation because it is going quite deep. Now where is the cord? So these are the cord structures.
Okay.
Oh no, sorry, probably this is vein. Just a minute. I need to dissect a little bit more. If it is not clear from that side, we can shift to other side. Because what sometimes happens, the lipoma and cord structure are so embedded with each other. Sometimes we are pulling the cord.
They are maybe with check.
Yeah, see, the vase is here.
Yes, vase is
So lipoma and cord structures are together. So we have to open this layer of spermatic cord. So this is a cord structure. We can appreciate now. It is going down.
So, Amit, your message to the audience is that you should always remove the lipoma of the fat.
Yes.
It is must.
Yes,
It is must.
that is a triggering this thing for recurrence. If you don't remove it,
Okay.
it will lead to recurrence because it again pull the peritoneal sac back
Okay.
to the
Yes.
inguinal canal.
Yes, the vas is seen very clear.
I just need to be sure that the gonadal vessels means,
Yes.
they are not visible very well.
Okay.
So I am just trying to dissect it out. Many times what happens if some layer is not cut from the spermatic cord, the vessels remains with the, see here are the vessels, they remains with the fat.
Okay.
So
Having the sense are like a momentum or
no, this sac is not there. See that we are very sure. This is a peritoneum, okay?
right.
There is nothing is going so deep into it.
Okay.
So peritoneal sac is not there. This is a
Pseudo sec only.
yeah,
Yes.
the lipoma of cord only,
Lipo.
which we are dealing with.
Okay.
Okay. So vas is dissected, but the vessels are still there. So I am just separating them from the fatty tissue. Pottery लगा.
આ શેની માટે છે? Umbilicus માટે.
Paresh, you can ask any question, no? Sumani, we are waiting for you.
चलो आवा दो. अंदर आओ.
દબાઈ રાખવાનું છે. ક્લોરેક્સિડિન છે, સેવલોન જેવું છે હે ને કલર. હા એટલે એને કઈ અડધી સ્કીન પર ક્યાં કે પેલા હીરો માસ્ક પહેલા કેસમાં પહેર્યો તમે? મૂકી દો ને પેલો કેમેરો અહીંયા મૂકી દો. क्या गया कैमरा वाला क्या गया? मैंने फोकस करना पका नीचे.
So here the lipoma is not as a entire globular. It is more of like a diffuse. લગાવ્યું છે.
Amit, you are trying to separate the
Yes, the
fat
from
from
the
the
cord structure.
cord structure. Vas is very clearly seen medially, so that there is no need to take care of the vas.
Yes.
Amit bhai, good morning.
Good morning.
I am Dr. Paresh Somani.
हाँ परेश भाई, good morning.
Kem cho?
बस
What is the lower limit of your dissection for vas?
It's when it curves medially.
Yes.
So that I probably achieved. I will sure before completing the dissection. But this is a cord structure, and the fat lipoma cord is there.
Gonadal vessels are unusually stuck.
No, this happens many times. This is a diffuse kind of lipoma of cord, where the lipoma is not very well encapsulated. So sometimes it asks a little bit
Vascularization of lipoma looks like.
dissection. No, it will come. Who copy do? So it's now separate.
This dissection is important for putting your mesh properly, no?
Both putting the mesh and avoid the recurrences, because this will pull the peritoneum.
How do you fix here the mesh?
Pardon?
How do you fix the mesh?
I use Stacker.
Stapler.
Yeah. So this fat is now separate from the So see, vas is very clear here. This is vas, and we just want to confirm that dissection first. Who copied?
Amit bhai,
Yes, sir.
this is called a surgery. First you thought that this is easy side.
Simpler.
Simpler. Now it has become difficult.
But the most important thing is we have to keep patient and follow the principle. There are no shortcuts. We have to follow the principle.
Yes.
And that is the charm actually.
Yes.
बताओ तो। So vas is now here, it is going deep. So that aspect is fine. This fold we have to remove, otherwise the mesh will get uplifted.
Yes.
Amit bhai, what is your choice of instrument for this dissection? This is always hook, or sometimes you can use the suction cannula also?
Suction, yes, we can use, no doubt about it.
Okay.
Suction is always a good, but majority time I prefer, because it gives a precise dissection.
Yes, so you mean to say you are more comfortable with hook?
Yes.
Okay.
Majority time. So this is the vas going in medially and inward. So that part of dissection is done. We have removed this fat flap, so it will allow us to put the mesh properly. And now see, the important aspect of lipoma of cord is this at deep ring it should be denuded.
Okay.
Wherever if you denude at deep ring, that is very essential. Then from there gradually go downwards.
Amit, you remove the lipoma or you allow it to be there?
No, it will be there only. I just want to dissect it out from the spermatic cord.
So it is not totally devascularized.
No. The deep aspect, it will be there only.
Then there is no chances of seroma?
Less likely, sir. I haven't seen because of this there is any kind of seroma.
And what precautions do you advise to prevent seroma formations?
Seroma are usually seen when there are large inguinal hernias. This is a small hernia, and the plane we are dissecting is quite deep to the muscle. So I don't think seroma is a concern in this kind of patient.
No, not in this patient, but routinely.
Routinely, for large hernias, I do take the pseudo-sac.
Yeah.
That is my preference.
And any kind of pressure dressings?
Yes, post-operatively, I ask a patient to wear tight undergarments.
Most important thing is to explain it pre-operatively.
Of course. All patients with large hernias, we have to explain for seroma, especially when the hernia is inguinoscrotal and indirect.
Yeah. And never aspirate.
As much as possible. Sometimes we have to, if it is very much symptomatic and a long time had gone. Then again, we need to apply compression dressing. But majority time it is possible to deal conservative only.
Amit bhai, I think on the screen Dr. Ankur is there.
Yes.
Ankur, you are on. Ankur? Amit?
Yes,
My
dissection is almost complete. I'm just waiting to clean the scope.
Hello.
Ankur, you are on. Ankur? બસ આ લોકોને કેમ કે અંકુર બાજુ કન્વર્ટ કરી દે
સામે ઓટી 1 માં આપો માઈક
બસ હા સ્લાઇડ મૂકો કઈ મૂક્યું છે અહીંયા આટલા લોકો છે ને
Hello.
અંકુર ભાઈની સ્લાઇડ ને હા બસ પેલું મૂકી દો Ankur, you are on. I think you can explain that what type of the hernia, what is the patient history. Yes, this is a Bhavanaben patient, umbilical swelling since 10 years.
Hello.
Ankur, you are on. E-tap. Ankur? Ankur?
ચલ બતાવો ને પાછો
OT1 માં કરો
બસ આટલું
OT1
પતી ગયું હું કાપી
ડોક્ટર અંકુર માં
Yes, sir.
OT1 માં OT1
We are ready with our next case. This is a 40-year-old female patient.
Yes.
She had undergone ovarian cyst surgery around 16 years back, and she have an umbilical swelling which is of around 3 centimeter in size.
3 centimeter.
Yes.
Okay.
So normally, what I have now we have made a protocol over here is that any umbilical hernia which is above 3 centimeter in size, in those patients we can go ahead with E-tap RS. So normally for small hernia we either use a small flower mesh or either IPOM, but for a big defect we can go for E-tap RS.
Okay.
So the most important step which we are now going to show is that the first entry point.
Okay.
So I'll just show you the landmarks.
Bus, yes. Show it from the exterior. Yes. This is seen.
If you can see the landmark, this is the seminularis line as we draw, as we show you in the first case also E-tap. So seminularis is the landmark of any E-tap procedure.
E-tap, okay.
So normally the first port placement would be subcostal trocar.
Subcostal, okay.
Subcostal. Then the second trocar will be just 4-finger breadth beneath it.
Okay.
And the third trocar will be another 4-finger beneath it.
Okay. Yes.
And the fourth trocar, when we do first, the dissection will be in the straight position, then J maneuver, we will go on the opposite side, and then after doing so much of dissection, we will go on the other side by doing the crossover. Also, E-tap RS is very good in females because such females who are, she has already undergone 2 LSES.
Okay.
They have a mild component of dye variegation. So normally dye variegation can be tackled with this procedure very well. The whole boginess or the lumpiness of the whole abdomen gets tightened up. So this procedure is very good in case of females.
Okay.
So we have just dissected, and the main step we have kept it for you to see.
Okay.
So after educate dissection, you can see this white glistening structure, which is the anterior rectus sheath. Can you appreciate?
Yes, yes.
So after seeing the anterior rectus sheath, we'll make a small cut. And after the cut has been made, we'll again introduce artery forceps through the same opening, and we'll go behind
અને પેલું બારણું બંધ કરી દેજો અને ત્યાં આગળ પાછળ એક પડદો લગાવી દે.
So during this first step, you should be very slow, because if you are going into the peritoneal cavity, then there will be a lot of problems.
Your basic goal at present is not to enter into the peritoneum.
No. So the basic principle of E-tap, any E-tap procedure, any E-tap procedure is that you have to first go posterior to the anterior rectus.
Anterior rectus sheath.
You should be very gentle. There are some instances. See, the trocar now is perpendicular.
Okay.
So if you go direct into the abdomen, you can injure the posterior rectus sheath, and then you can make a pneumo in that case, and then the procedure you will have a very great difficulty in making the space. So normally the first step is like E-tap, as I discussed to you. The posterior or the inferior plane should be white. You should see white thing. That is the posterior rectus sheath. And anteriorly, superiorly should be the muscle. So it will be always red. So we are in the right plane.
Okay.
So I'll just insufflate. I'll go inside. I'll come back, and the tunnel is made. Yes. So we are in the right plane.
So trocar dissection is fine. There
Yeah.
is no need for the finger dissection.
Yeah. So many of the people use balloon over here in this space.
Yes.
But normally balloon is not required. If you get trained by just blunt dissection, it can be done very easily.
Blunt dissection with the tip of the telescope.
Yeah.
Okay.
So now I know that I'm in the right plane. I'll fix my trocar so that the gas leak will also stop, and also the trocar will not come out.
Okay.
So I'll just focus. So we are just fixing the trocar. As I showed you in the first case also, we'll use the same gauze piece which we used to compress.
Hello.
Amit, you are audible.
Yes, sir. But I have completed my dissection on the right side also.
Okay.
So the thing is, we can see the peritoneum. There is no buttonholing. And here, this is vas. These are gonadal pedicles. The parietalization is adequate because deep ring is here. So we are quite long. The medial space is fine. Retropubic space is fine. This is on left side. We can see the entire thing. Here the pubic tubercle, and lacunar ligament, and Cooper's, and this is a lateral aspect.
So basic principle is
Yeah.
follow the white.
Yes, follow the white.
Follow the white.
So now I am putting the mesh. I am also going to use the anatomical mesh from BARD. So we have to just first determine right and left. So right now I am taking the mesh from right side. It is of large size, 11 by 16 centimeter.
Yes.
And the best thing is you have to just roll. It is easy. And you can insert it from the 10 mm trocar.
Okay.
Easily. Yeah. Fine. Give me another grasper. अच्छा 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 यहाँ अच्छा. So this is the medial end.
This is again 3D mesh.
3D mesh, yeah,
Okay.
anatomical mesh from BARD.
Okay.
It is of large size.
It is a large
It is
size.
16 by 11 centimeter. The M is suggestive of medial aspect,
Okay.
and we have to bring that end towards the symphysis. Okay. हाँ, आइए बताओ. So this is a lateral aspect. So this is the beauty of this mesh. It will get adjusted to the anatomical position very quickly. Now the next step is to determine the lower flap, lower aspect of the flap. See, I am pulling the flap and there is little bit elevation of the mesh from here.
Yes.
So I have to be sure that it does not get elevated. So now it will not get elevated. See, there is now, it is elevated just because of the gonadal vessel. But
Yes.
the lower end of the flap is good enough. And Dursi bata, mesh. So mesh is lying absolutely flat to the anterior abdominal wall. So my preference to take is here at the tubercle, the Cooper's ligament.
Okay.
And another tack will be in the anterior, and one tack is a lateral. That's all.
Okay.
Above the iliopubic tract. I don't want to injure any nerves there. Okay. Before starting tacking, I will apply the another mesh, and then tack all together. બીજી mesh આપી દો left side ની. ના ના ચાલશે. આવી જાઓ તમને.
Amit?
Yes, sir.
Yes, now the mesh is applied nicely. People has appreciated very nicely.
Thank you, sir. I think Dr. Ankur is
Yes,
doing a very interesting
that-
case also. So before, I just want to comment one thing. I use tacker for peritoneal closure.
Okay.
And the important thing in using tackers while to close the peritoneum is you have to do head elevation. If you do head elevation, the both flaps of the peritoneum will come together without any kind of tension. And that is very essential. Otherwise, tackle will cut through.
Okay.
So, if possible, I will come again just to show how to close the peritoneal flap.
Okay.
Okay.
Now we are switching over to
Yeah.
Ankur.
Thank you.
OT number 1. Yes, Ankur, you are on. Hello? Hello?
So the device which I am using
Okay.
is LN bipolar. So
Okay.
bipolar is very good in this area.
Okay.
You get less amount of bleeding.
Okay.
I am very fortunate today that Dr. Rajni Sanghvi sir is assisting me.
Yeah.
Actually, and no sir. I have a very good assistant, Suraj over here. They are very trained in laparoscopy, and the anesthesia is given here by Dr. Preeti madam.
I think, Ankur, there is no divarication of the recti.
Sir, once we'll do crossover, we'll see, sir.
This is all you are on the right side, left side.
Yeah, still I'm on the left side.
Yes.
See, normally divarication, you can see it pre-op, and then once you start crossover, then you can get the defect more.
Yes.
And you will appreciate it better.
That
the
vessel
divarication is not major. A small amount of only divarication is there, but in such kind of female patient, they are very happy with this surgery.
Yes.
So you can repair their whole
weakened portion, yes.
Yes.
You have made a very good tunnel on the left side, very nice. We
Yes,
can
sir.
see the vessel downward, in the down part. That is the inferior epigastric vessel?
Which, sir? Yeah.
The-
So normally, I'll just show you. I was inserting the
Needle.
yeah.
Yes.
I'll just insert the trocar, and once both the instruments are there, I'll just show you the anatomy.
Okay.
So the
So, Ankur, the needle is always a pilot. So before
100%, sir. I was
Yes.
just going to make the statement that whenever you are 100% confident,
Yes, then and then put a trocar.
you are 100% confident with your finger that this is the place, but until and unless you put the needle, you are not knowing where it is going to come out. So once we are inside the abdomen, then you will have a lot of struggle because the gas from below will keep on
Disturbing
closing. Yes.
Yes.
So it is better to always have a needle inside, and then you are 100% sure that it is your trocar is also going to come out on the same side.
Same side, yes.
पानी ले लिया सर? पानी अभी दो. So in hernia, it is always a stepwise. What I tell all the young surgeons who are going to learn laparoscopy, that the first surgery to learn is TAPP. Then you do a bit small, a good amount of cases in ETEP, and once you are excellent with ETEP, you can then start doing ETAP RS. So all this surgery require a little bit of, because one step you miss and then the whole surgery is in struggle. So initially we also had a lot of problems.
Yes, the trocar is placed very nicely. There is no bleeding. Vision is clear. Ankur, you are more comfortable with bipolar.
Yeah, definitely.
Definitely.
See, this is the best instrument which I have ever seen.
Yes,
because
yes.
it helps in dissections. The jaw, if you see, this is a dolphin jaw. So normally it coagulates and cut at the same time. So this is the inferior epigastric which Gasura sir was saying. So inferior epigastric is going like this, and these are the branches. The branches which are going, these are the umbilical branches which are going horizontally.
Okay.
This patient has 2 LSCS. So normally we are expecting some amount of adhesions in the pelvis.
Okay. So you mean to say that bipolar is even better than the harmony or the thunderbeat in this case?
See, normally,
Okay.
economic wise, if we see,
Okay.
if we are in a small setup,
Yes.
there are cases which can be done with bipolar, but already, see, normally harmonic and thunderbeat has its role in many surgeries. If you are doing high-end surgeries, then only bipolar will not suffice.
Okay.
In those surgeries, you will definitely require, but in normal routine surgeries, you will never require
હા પ્રેશરે ડાઉન કરવાનું છે ને હેડ અપ કરવાનું.
So that in hernia bipolar is
હા.
your choice.
So in all surgeries, you will never require thunderbeat. And normally, a young surgeon should always train with minimal, like monopolar,
Just-
bipolar.
પ્રેશર 10 કરના.
Okay.
હા હેલો.
Yes, yes, Amit.
Yes, yes. But sir, I was just going to conclude it. You can see the both meshes in the
Yes,
midline.
you are seeing.
The M at the same level, and the tackers, single tags applied at the Cooper's ligament.
Okay.
There is a only single tag for both mesh in the midline.
Okay.
So we have saved one tag.
Okay.
And one tag on the lateral side on both side.
Yes, yes.
Huh.
yes. Very clean and
Okay.
neat surgery.
Yes.
It is a very
Now,
good. nicely seen.
the next thing is we have to ask to decrease the CO2 pressure
Okay.
and ask for head elevation. Head elevation karo. And then do peritoneal closure. Otherwise, the weight of sigmoid will pull and the tackers will slip.
Okay.
Flat kar nakho patient ekdam. Flat. હા થોડું અપ કરશો તો વાંધો નથી. Okay.
How much tag do you apply, Amit? It requires 2, 3, 4, 5?
No, for peritoneum as much as needed. Most probably 4-5 tags are enough.
4 or 5 tags are enough.
Left side પહેલા બતાવો.
The tag that you prefer is absorbable or not?
Always absorbable, sir.
Always absorbable.
And this is why I keep the thick layer. See, if the layer would not be thick, it will tear.
It will tear, yes.
So I want, and after a head elevation, you can see I can pull the peritoneum quite up. We have to be careful for inferior epigastric vessels here. કશું ના કર. See, here only 3 tags are enough.
Yes, Amit, nice.
The entire fold is wet. Now the same thing on the opposite side.
Amit bhai,
Yes, sir.
you just spoke about this procedure. What do you call it? Application of the tracker, overlapping the lower flap with the upper flap?
Yeah, we just want to avoid a max exposure
Yes,
to
yes,
the
yes.
intra-abdominal
But
content.
you said some words
Overlap, that's also.
on that only, na?
Yeah.
Okay. So you did a very good dissection, really. We all appreciate your dissection.
Thank you, sir. Thank you. I have learned laparoscopy from BHAVIN bhai only. So he is my mentor. My first trocar was, I placed my my trocar in PARTH hospital under guidance of Dr. BHAVIN bhai and Pankaj bhai. So there are only
Beautiful.
3 tags and everything is closed.
Very nice. Excellent.
So
Excellent
this-
surgery.
Yeah, this maneuver is very important. We have to do head elevation, otherwise this is not possible.
It minimized the time also.
Yes. And now the last, I will just spread the momentum as much as possible. So that's all from my side. साफ करना?
You will put the momentum just,
हाँ, just try to spread momentum as much as possible. That's
so
all.
no addition between the.
Yeah. Always take all precautions which are possible
Yes.
to avoid any undue complication later on.
Yes.
पकड़ना पीला हाँ बैठो साफ कर दो स्कोप साफ करो
So you have nicely shown the bilateral TAVP surgery to our resident also.
Thank you, sir.
Your this trocar is below umbilicus, I think.
Pardon? Huh.
Your camera port is.
Hello?
Your camera port is through the
Through umbilicus. Actually, there was small umbilical hernia. So I want to suture it. So
yes, yes. So you have put through the umbilicus.
Yeah, through the umbilicus. So that I will suture. So one more procedure to benefit the patient. So this after you do head elevation, you can see the momentum will go so deep. And now if we see the flap, it will see flap is here and momentum is there.
Only momentum can attach it. Yes, yes, yes.
Okay, so that's all.
Thank you very much. Very nice surgery.
Thank you, sir.
Okay. Please switch over to, yes, Ankur is doing on the right side also.
Ankur, you are on. You are
Yes,
audible.
sir. Yeah, so we have now dissected. We have dissected the whole right side, and now we are ready to do the crossover.
Okay, you are crossing the midline.
Yeah, so now we will do crossover. So as I told you in the morning, the best instrument here I prefer is the spatula.
Spatula.
Because spatula normally it has both the properties of, you can do blunt dissection also. I made a small cut over here. So the energy device which I am using right now is the cut. So when you cut, you get a very sharp, like you are cutting it with a scissors. Some surgeons also use scissor at this place. So as in morning I told you, we should take this down. Over here, the fat is going to go down. And we should be very gentle and very slow in this area.
Okay.
So
Here,
falciparum. It is the falciparum.
Ankur, here it is reverse. The fat should be down.
Yeah,
not up.
Yeah.
Yes.
So this is actually the falciparum. So if we go below it, then we are going to go into the peritoneal cavity. So this falciparum should go down over here. And if you are gentle, it will definitely go. It will take some time, but this is a very crucial step in crossover. So in surgery, there are special steps where you have to decrease your speed for a better outcome.
So it is a combination of blunt and sharp dissection.
Yes,
both.
sir. Yes, sir. So
This
in
is
one hand, I have kept my bipolar.
Bipolar, ready.
So at any point where there is some bleeding, I can just take care of my oozers. And on one hand,
Ankur, by other side, which space is there?
see, we are still not reached into the other side.
Okay.
Yeah.
So it may be the preperitoneal.
Yeah, it is preperitoneal. So it is. This is the.
Retroductus.
No,
okay.
we have not. See, normally the main crucial step in crossover is this step.
Okay, preperitoneal space.
Yeah. So
okay.
I'll be showing it you step by step.
Okay.
થાય છે કે નહીં? Okay, so to see whether there is muscle on the other side, yeah. So Dr. Amit is there in our OT and is helping me to see where the other side is there. So normally for this, again, spatula will not work. So we'll have to change our instrument to hook. So normally whenever you want to see the opposite side muscle, you'll have to give a small twitch. So normally you fire and there is a small twitch. So then you confirm that it is the other side. Can you appreciate the twitches? મને લાગે આખું રેક્ટસ જ છે. Sometimes you can injure the linea alba, so it is better not to cut too much until you are sure. बताओ ना आवाज में. So it is better to go slow in this area because this is the crucial step. If you are wrong in this step, then your whole surgery will suffer. We are not getting the rectus on the other side is because she has a divarication. Okay, we can see the muscle now.
Yes, now you can see.
So we can move up and down on both the side. Once we are in the right plane, the surgery is very easy. then there is no problem. Anatomical then. Hook here, we are using hook in this area because we can just go up to the linea alba where it is joint, and there we are able to cut. Normally if I am using a spatula, then I am not able to hook it. Thank you, sir. So we'll make the plane, we'll insert a new trocar, and then we'll move our telescope back to our subcostal plane. And when we are top-down view, then the surgery will be very, very, very fast. So this is the right plane. This is the neurovascular bundle which we can see. You can see three things. No artery vessel. All the three are traveling together. So we, by chance also, we can't injure the neurovascular bundle. If you see only the vessel, you can take care. You can coagulate or cut the vessel. There are perforated which are going directly perpendicular. And if you see these neurovascular bundle, they are on the lateral aspect, near the seminularis. I'll just show you once again. See, can you appreciate?
Yes, yes.
You can see a white structure.
Yes.
You can see an artery vessel all around it. So this is a neurovascular bundle. So if you injure the neurovascular bundle, then your rectus muscle will get atrophied and then they'll not function. So you must avoid injury to the neurovascular bundle.
Same like tar.
So these are the perpendicular perforator. So we can take this. No. Needle. 5 mm. So the total trocar will be using our 4 trocar to 5 mm to 10 mm. So again, I can feel that my finger is very nice, and I'll be able to, you can see. But still, I'll not be overconfident. I'll put a needle inside. I'll see where my needle is coming out. If it is not coming out, see. It is not coming out. I'll take it a bit anteriorly. Yeah, over here. And now I'll put a trocar. So even if I am 100% sure, I can be wrong. So needle is must to show you the direction where you are going to come. Because see, if your trocar is entering, still we have not created Nemo. And because of that only we are able to work properly. So if you are creating Nemo, head लो ना break करी दो थोड़ा. If there is Nemo, then the space where you are working is not adequate, and you will not be able to work properly. Okay, sir. Sure.
Ankur bhai, this is Amit.
Yes, sir.
I just giving some brief about this procedure and the complexity with it, with your permission.
No, definitely, sir. Definitely, sir. Because this surgery looks very easy when someone else is doing, but it is very complex. It is not that easy.
And it is difficult for you to comment continuously because you are doing excellent dissection, and it asks for total focus and concentration.
Yes, sir.
Yeah. So just to let everybody know, this is a really one of the complex procedure as far as third space hernia surgery is concerned. And because number one is limited space, number two is we have to do in a isoplanar dissection. Means camera is not between two instruments. Camera is on one side and two instruments are on the other side. And we have to be very precaution to avoid any kind of pneumoperitoneum, otherwise the surgery become very clumsy. So he's doing from left side right now, and very nicely crossed over to the right side.
This is side of the umbilicus hernia?
No. Still it is, we have to wait, yeah. He is just cutting the medial edge of the left, means linea alba, yeah. Left side of the linea alba to increase the space. And this is the right side, right end of the linea alba.
Kasura sir, you can see the amount of space which is there in between the two leaflets.
Yes.
So we are very high, still there is a lot of divergation.
So yeah.
So we had difficulty in crossover because of the same reason.
True. And we have to be very patient and gentle because, believe me, this asks for very good physical strength also. I am sure Ankur must be feeling the shoulder pain by this time.
I sat down, sir. If you can see my position, I sat down because I'm working on the roof.
Yeah.
I was bending too much, so so I sat down.
And the another maneuver Dr. Ankur mentioned, just I reiterate, is breaking the table. So when you break the table like this, the abdomen will come up, and then the dissection is little bit easier. Otherwise, your instrument will collide with your the patient's face or shoulder or subcostal region. Then it is difficult to maneuver during this surgery because we are working at the roof. This is left side, that is right side. Now the camera is quite, I think he has shifted the camera to the upper port.
Yeah, it is in between.
Yeah.
So there are 2-3 maneuvers which are to be done, shifting the trocar up, down. So now we'll be working from above only.
Yes. So after a while, you will see what is called as a
volcano sign.
Volcano sign, yeah. I forget the name. I think there is a small peritoneal rent, yeah. But it is bound to happen as
the peritoneum is very thin over here.
Yeah. As you are going near to the hernia side, the peritoneum gets very thinner and thinner, and it is always going to get open. So that's the midline, the wide open linea alba. Okay, now it's very nicely seen, the two ends of the linea alba.
Yes. So we are near the umbilicus.
Yes, you are near the umbilicus.
That is umbilicus, side of the umbilical hernia.
Yes. We need a very good camera person also. I think
Dr. Rajnish sir is right now showing me the camera.
Oh my God, great. See, the important thing is all time the working place is in the center, and probably that is the hernia site. So this kind of hernia surgery needs, of course, a skillful surgeon, but with also a good assistant, the camera person, the anesthetist, because we have to keep the blood pressure low. Otherwise, the entire field would be quite oozy, and once that bleeds, the vision is compromised. So that's the hernia. You can appreciate the fat is entering to the defect in the linea alba, and he is reducing it nicely. So it's called volcano sign. We can see
the two edges.
Yeah.
And this is going like that.
The crater in between.
Yeah.
There are many students, so I'm not sure you are means laparoscopy surgery for hernia routine in your units or not, but I think when you think of private practice, patients are going to ask for it. So better you learn. We were and so what happens, the content is quite means significant. The defect is not that big. So it is difficult to reduce. We have to do it patiently, and he is doing nicely right now, believe me. And the another thing that we should push the content into the peritoneal cavity. Try to avoid bring in this plane. Otherwise, then it will be really difficult to push it again into the peritoneal cavity. So attempt is always to push directly into peritoneal cavity, rather it bringing in the our pre-peritoneal space. Yeah, the defect is very well appreciated. The upper edge of the defect is very well appreciated.
Mainly नजीक आओ सर. So we have reduced the sac.
Yes, yes.
You can appreciate, yes.
Sir, नजीक आओ sir. So the next step is that you should be very flush. There should not be too much of holing of this posterior sheath. No doubt the peritoneum is very thin, but you should not open the posterior sheath so much that you need to suture it so much. So the suturing should be at the minimum posteriorly. So the dissection should be in such a way that posteriorly you get not too much of suturing work. Because E-tape RS is good for patient, but for a surgeon, there is a lot of suturing required.
Yeah,
So you have to suture on the roof, which is the most difficult part of suturing. And then if you make a big hole on the posterior aspect also, then you have to suture that also. So a lot of suturing work is to be done. And the position is also a bit awkward. So the posterior opening of the wound, the peritoneum should be as minimum as possible. तो टेबल ऊपर करे तो टेबल सर नजीक आओ. Very not sir. काही ना काही करिए. आवृत्ति थोड़ा बता दो. या साइड में एंगल ऑप्शन. नहीं तो रिपेयर करवाનું છે આપણે. આ બાજુ બતાવો છો. હા. એ તો રિપેર એટલે જ ને આમાં રિપેરિંગ વર્ક ઇઝ ટુ મચ. Good for patient that he is not going to have a composite mesh, but difficult for a surgeon. But what I feel that each and every person should know every method, so that you can have a bailout. So if there is a problem, if I have taken a patient for E-tape RS and I'm not able to create a plane, then at the same time you should be prepared and explain the patient that we can do an IPOM also for the same patient. So I had a similar case who was around 110 kgs of weight. In that patient, I thought that I'll do E-tape RS, but in that patient I was unable to do. Pneumoperitoneum creation. So because of other problems, and in those patients you don't want to go to the peritoneal cavity, or some patients have IBS. So they tell us that we are not wanting to go you to go into the peritoneal cavity. So in such patient you have to do an E-tape repair for inguinal hernia. So there are some situations where you must change your procedure.
I think over the years, during my residency and now after 15-20 years, what is very well established is the retromuscular mesh placement is the best
exactly.
for long-term outcome.
Exactly.
So nowadays we rarely do only mesh plastry unless until there is some contraindication to any kind of retromuscular repair. So majority of our repairs are either pre-peritoneal or retromuscular, means in Reeves Stopa plane. In inguinal hernia also we usually do TAPP, so again that is a retromuscular plane.
And because as per the laws of physics,
it is the most physiological plane.
Yes, and the recurrence
is very less.
Very less.
So initially, the recurrence in laparoscopic surgery was because the technique was not so much taught properly and not done properly. Nowadays, the technique is so much done properly. There are a lot of courses which are asking the surgeons to learn a lot of good laparoscopic surgery, and because of that, and the mesh and everything has improved. The optics have improved.
Yes. And the understanding of anatomy is also improved.
Exactly.
Because not only the plane, the neurovascular supply to the muscle.
Exactly.
That is also now very clear. Everybody understand it very well. And that's why even after this much dissection, you will not find any kind of neurovascular injury to the muscle, which will lead to any kind of weakness or damage later on.
Definitely, sir.
So just as we started discussing about anatomy, can anybody share what is the neurovascular supply to rectus muscle? If anybody want to volunteer. So see, the basic thing is it is from lateral aspect, from the semilunary going horizontally. And it is in between internal oblique and external oblique, and then it goes towards the anterior rectus sheath. So whatever dissection we do between the muscle and the posterior rectus sheath is not going to harm the neurovascular supply to the muscle. So that's why this plane is very important for ventral hernias or any kind of abdominal wall hernias.
That principle is also applicable to TART surgery.
Yes, yes, the same thing, yeah.
When you do open TART surgery, same principle you have to keep in mind. You have to go just below the neurovascular bundle.
And the second thing is, if we put mesh here, it will be in covered both sides. Means it's a sandwich. There is a posterior rectus sheath and peritoneum behind, and the anterior rectus sheath in front of it with muscle. So whenever patient exert, the mesh will get sandwiched between two layers. So that's why the recurrence rate is less. We don't need to fix it so much. Because naturally it get fixed to that particular defined space. So we can see there are few vertical vessels from sheath to muscle or muscle to sheath. But these are not important because they does not harbor nerves. The neurovascular bundle is always going horizontally. So these verticals are, you can cut. They are just small vessels, and there is not a harm to cut them. But if the neurovascular will go from lateral to medial aspect, and if you observe properly, you will able to see a whitish nerve traversing, glistening whitish nerves. So he is now cutting the right side of the linea alba very meticulously, and in a short while he will able to reach to arcuate ligament. Of course, after cutting the left. We can appreciate the linea alba is quite wide. I think probably 3 centimeter or 4 centimeter probably. I'm not sure.
Yes.
Yeah.
So for normally females will definitely be very well. I mean, they will appreciate this surgery very
Yeah.
well. So normally their petulicity will also go because we are repairing her linea alba.
As he is approaching downwards, we can see the recti are converging now. So the width of linea alba is decreasing. That's a good this thing.
See, both are coming
together
now.
Together now. And probably I think in a while the arcuate line also be visible.
Definitely. So if you have seen that I'm not cutting this thing.
Yeah.
So if I'm cutting this thing, then I'll have to suture all the thing.
Everything, yes.
So your dissection should be, your effort in the end should be less.
True. And the natural peritoneal barrier will remain. It's
Exactly,
always
exactly.
good to avoid post-op adhesion. Excellent dissection, Ankur.
Thank you, sir.
Yeah,
I
very nice
approve. Thank you, sir.
Everything is seen very neat and clean.
See, if you have a bit patient in such kind of cases, there are surgeons who says that slow is fast. If you are going slowly, step by step, inch by inch, then the surgery, there will be no oozing, no bleeding, and you will be able to complete your surgery even faster.
Agree.
So always in laparoscopy, it is slow is fast.
Yes, yes. True. Because if there is no oozing and the planes are fine, you need to not to change the instruments very very frequently. The camera person is also happy, so he will show properly.
Yeah, everything matters.
Yeah. Otherwise, his frustration will be there. No, sir. We are we are on lower aspect. Now we will reach up to.
So we are around 7 to 8 centimeter below the umbilicus right now.
Yes.
And we are, after opening this last patch, we will be reaching the pubic symphysis in a short while. So I have changed my instruments. I have come to the lateral end because superior port I was not able to reach down. There will be some additions over here because patient has undergone to LSES.
But do you feel to dissect furthermore because the
yes, sir. I feel that the mesh should reach up to the pubic symphysis.
Okay. Because otherwise the muscles are converging very well. So I
Yes,
probably
sir.
the
I'll see if it is if everything is fixed, then I'll not.
probably it is going to be a little bit difficult because of previous surgeries.
Yes, sir. But I'll just be finishing in 1 to 2 centimeters.
Some dissection is pending.
As it is always said that in hernia the placement of mesh should be around 3x, 3 times bigger than the defect. So what I feel that if you are repairing this, I'll go a bit lower down so that the mesh is also completely flat. કેમ આજે આવું રાડો યાર દુનિયા પીછે So I thought that I'll use bipolar, but today I am not having good luck with bipolar. Now I have started using bipolar in lap colis also.
Okay.
Yeah. So there was a meeting from all the zones in Delhi, and where they decided, Dr. Roy Patankar, under whom I got trained, was also a part of that meeting, and then we always used to have small sessions when sir used to come back from such kind of meetings. So now the whole team, that is the Pradeep Chaube sir's team, Pannali Velu sir's team, Roy sir's and the Hyderabad team, they all have decided that in lab chole also it is better if you use bipolar.
I agree, bipolar is always a good instrument. The issue with this bipolar, what you are using, is it get heat quite significantly. That is my personal perception. And you have to be very cautious.
Definitely.
If you touch to any bowel or any important structure, I am a little bit afraid of delayed injury because of the heat.
Okay.
So I also use, but as we discussed, I am a fan of hook.
Needle. Still I am very up, so I'll have to dissect.
So this is how far from the hernia defect?
It is around 5-6 centimeters.
That's good enough. Because
but
I think
see, normally we are not going to fix the mesh, so I feel that the more it is lower down,
okay, fine, yes,
it will. The purpose of Pascal's law will suffice.
Yes, that is true.
So I'll have problem in very small area. So once this small area is dissected, the whole plane will open up. And what I have seen that placing a big mesh in ETAP RS, the chances of recurrence and everything is very less. And we should place a very big mesh in ETAP RS.
Yes.
ના હજુ તક નથી, થોડુંક આપણે બહુ જ ઉપર છે, અહીંયા જ છીએ જો આપણી નીડલ અહીંયા છે. सूरज ચાલતું નથી યાર. નવું લઈ લો ને, બીજું નથી. લઈ લો ને. So in US, after there were a lot of litigations in patient whom surgeon had performed IPOM, now they have moved completely toward ETAP RS. So Dr. Igor Bilyansky, who is the pioneer, has propagated, and now we have almost a different AWR Surgeons Association only focused for hernias. So normally hernia is a very complex surgery, and initially we used to think that everybody can do hernia, but I feel after laparoscopy has taken hernia to a next level, it is better to get trained properly in hernia, and then I feel we have to apply all the training in performing hernia surgery. and you should know your energy device very well. So even if your bipolar is not working, you should be well versed that you'll be able to perform your surgery with monopolar. So energy device is the must.
So here nice dissection is going on in the previously operated patient and there is a significant fibrosis. So he's following the muscle, there are twitching and he is just trying to stay at the muscle. So that is important. How to deal in this situation, it's a very nicely being demonstrated. Anku, your comment, any other tricks?
Definitely, see normally we have to, if there is bipolar or harmonic in this area is good.
Yeah.
Twitching with monopolar is a bit high, but my bipolar is not working. And see, normally what we used to follow is that we have a different bipolar, but right now it is not autoclaved. So I'll not be using it.
Absolutely. It's
so
not.
Yeah. So in hernia, there should be some principles which I always tell. Again, I'm telling. I always tell my brother and sister that if we have infection in such patients 1 year has gone.
No.
So until and unless, whenever you start a hernia surgery, this thought should always be in your mind that if we are doing a hernia surgery and if the patient is getting infection, his whole year is going to go. And for the whole year, he is going to curse you.
Yeah.
And whenever the patient you see in your OPD, your morale is going to go down. So there are other reasons also for infection. First is the sterility. Second, there should be less amount of bleeding.
Yes.
Whenever there is bleeding, you should have good amount of hemostasis.
And tissue respect.
Definitely.
Yeah.
You should not cut such tissue that at the end they are going to get necrosed.
True. We should avoid all kind of necrotic tissue.
So this is the perforated. This is not a neurovascular bundle.
Yeah.
If you can appreciate it.
Please continue Dr. Ankur's OT. So there we can nicely see the inferior epigastric going up, right side. And
mesh preparation. So always in E-tape RS, you should have a mesh which is larger mesh.
Yes.
You will always have to measure. There is no fixed rule. 15 by 15, 20 by 20. It depends on the patient. So you should have a bigger mesh which you can tailor. And I'll be showing you few techniques for rolling, unrolling and all those things. That will save a lot of time and energy for unrolling the mesh. Because outside we can do it easily, but when we are in a closed space, it is very, very difficult. So few fibers here, and then we are done. ચાલશે સાહેબ મને લાગે અહીંયાથી ઓહો we have reached. ના હજુ તો સુચરિંગ કરશું. V-lock. So I'll be using a Vlog 0 number, 45 centimeter.
So you have reached up to almost symphysis.
Exactly, up to the symphysis.
Yeah.
Lot of adhesions are there, so
True,
I'll
true.
not be opening it because we
No.
are very much lower down.
Yeah,
now.
yeah.
We are almost suprapubic.
So your next step is you are going to close the peritoneal defect?
No. See, once what had happened that first I made a mistake of closing the peritoneum first. But if there are some holes on the lateral aspect,
yes,
we'll keep on having that pneumoperitoneum.
Yes.
So from that day I have learned that always suture the roof first.
Okay.
Because roof suturing is a lot of work.
Yes.
So
And
first always suture the roof, then you go for the peritoneum.
So that's a good tip. And for roof suturing, where will be your camera and your working trocars?
Same, I'll just be showing it.
Yeah.
I'll be showing a technique. બતાવી દઈશું આપણે. એ પેલી બાજુનું ચાલતું હશે ને. I'll be just showing a technique of inserting a very big needle into the abdominal cavity.
Okay.
So, સાહેબ આને બતાવજો. કીબોર્ડ ઉપર લઈ લેજો. So we'll be removing the trocar first. I'll put my needle holder inside. I'll be holding my suture material and then I'll go. હવે અંદર જવા દો. અહીંયા બતાવી દો. ગરમ પાણી તૈયાર રાખજો. So any size needle you can insert by this technique. Actually, I learned this technique from a gynecologist.
Yeah.
So if you see, the whole whole thing has come inside.
Very nice.
I had no problem in inserting the trocar also. So this is a technique which you can learn. Insert a big needle inside the abdominal cavity. Otherwise, you have to make. See, if there is no this V-lock has a blind end on the other side. So if you are making a small incision also, if we are using a small incision, then also it is difficult for the blind end because it is a big dilated thing. See, I'll just show you. This part has difficulty in going inside, and there are sometimes there are instances where it get broken up also. So for suturing, turn કરવું પડશે ને fast. પાણી લઈ લેવું છે?
ના.
So for roof suturing also the needle, the way you have to hold it is also a bit different when you suture the lower ends. So three-step technique. First you hold the needle, you turn it on the other end, and you hold it. So this is the most physiological way in which your wrist is not going to damage. If you can have a look over here, there is only pronation. I'll just do so much. But if I am holding the needle in the right way, which we suture the floor, then I'll have to rotate my wrist completely. So just by suturing the roof, I'll have a severe wrist pain. So you'll have to hold the needle in this way.
That's true, and by doing so, your instrument will not cross.
Exactly.
That is very important because if
this
you
this is very simple. Just pronation, supination.
Very nice.
Yeah.
And I'm not sure, but I also I'm always comfortable to have a camera between two working hand while suturing. Dissection we can do keeping camera on one side, and but suturing, it is always better to have camera between two working hands.
So, see what I have done, you see each and every step. Each and every step I have broken it very precisely.
Yes.
So once I have passed my needle, I have hold it by the needle holder. So I will not waste time again in adjusting the needle.
Yes.
Second, I'll take this hole and then I'll again take the next bite. So my one more step will reduce.
Very nice.
So when there is so much of suturing, your each and every, see, I'll be holding it in the same way I have to suture. I'll use my other hand to pull. And when you have so much big suture, there are going to be some problems. But if you do it this way, the time will decrease.
True. And another thing, I prefer needle holders in both hands.
Okay. Yeah, there are some, my teacher, my guru also do the same thing.
Yeah.
But I'm comfortable with using a Maryland.
True, true.
Yeah.
There are two reasons. Of course, the needle holder has a good catch, so it will
Definitely.
hold the needle well. And second, I don't want to spoil my Maryland.
But what I have felt is that
No, you are doing really nice.
what I feel is that needle holder, sometimes they are so much heavy. So
Yeah,
if you use both needle holder in both the hands, then sometimes there is a lot of problem after doing so much of suturing.
I agree, and you raise a really nice point about the instruments. I strongly believe that we should invest in good instruments.
Definitely. Pressure.
And for me, the stores or SQ-Lab needle holder, they are very lightweight, and agree, they don't give so much pain.
But sir, see, they are very costly.
Yeah, they are costly, but
I'll just show the instrument which I am using from Ohm. I have seen that this needle holder is the king of all the needle holders.
Okay.
Because the posterior end is the same as we have in other open needle holders. So it is very comfortable.
Yes.
I'll just show you in some while.
It has that finger.
Exactly.
This thing.
It is cheap, and in your beginning phase you can use